Good afternoon. I think it's afternoon already. Good afternoon, everyone. My name is Allan, and I'm doing a presentation titled Mortality and Associated Factors in End-Stage Renal Disease. Patients admitted at the care next between the years 2017 and 2021. So I'm doing medicine in my 5th year, and I appreciate that all of you are seated here to listen to our presentation. So our supervisor is Dr. Teresa Kenyari. I have to acknowledge her in absentia, and as well as the heavy team. Ruth is here and Vincent. We appreciate that they took their time to nurture us and to sponsor our research. So that's the acknowledgement that, as I've already mentioned. I also want to appreciate the AMSUL Scientific Conference Committee for organizing such a platform for us. So overview, that's everything that we'll be going through in the next 6 minutes. So background, chronic kidney disease is a known public health concern globally. And we have a prevalence in the global stage at 13.4%, while Africa stands at 10.1%, where we estimated 4.9 to 7.08 million of patients with ESRD require dialysis globally. So it's been adopted as, hemodialysis has been adopted as an alternative therapy for patients with ESRD in Kenya, where most patients cannot afford renal transplantation actually. So this study focuses on the patient mortality and the modifiable risk factors among end-stage renal disease patients in Kenya. So the background of Kenya, as we all know, it's a poor socio-economic status country where we have a limited access to care of patients suffering from end-stage renal disease. And as a consequence, it has turned to be one of the poor outcomes associated with this. Point to note that NHIF covers 2 dialysis sessions weekly for end-stage renal disease patients. Now, each session lasts for 3 hours, and I have a question to my audience. Do you think this is really adequate for the management of end-stage renal disease patients? And as today, as we speak, we have a lot of our patients who pass due to end-stage renal disease patients, and majorly it's because of such kind of things. In a study we did, a comparative study with Ethiopia, it actually showed that dialysis of more than 3 hours in a certain point in time during dialysis would actually register more better outcome as compared to 3 hours as it's done in KNH right now. 3, also noted that we have a lack of renal registry in Kenya. As compared to other elite countries like the United States that has a registry for all these people. So that means we have very few data that would be helpful in helping us manage this. So the rationale for this, I've already mentioned this, but I also want to make a mention that there's no study on associated factors with mortality in ESRD in Kenya currently as we speak. So God willing, this would be the first published study in our country, Kenya. So the objectives, our primary objectives are to determine the mortality and associated factors among ESRD patients admitted at KNH. And the second objective was to determine the socio-demographic factors as well as the clinical factors that are associated with mortality among ESRD patients admitted in KNH. So just maybe fast enough, this was a retrospective study. We did a sample size of 252 patient records using the Fisher's formula. And then we did a lot of secondary data. So that means we obtained our data from the medical records. And then we used Starter 17 as well as obtained ethical approval for the same. So the results were actually from the records that we had was the male patients were more predisposed to death, where we had a percentage of 60% who were diagnosed with ESRD as compared to the female counterparts. With the insurance as well, a lot of patients used NHIF, and then most of the patients lived in urban centers. So we want to compare the data and see. So the slides are not so clear as compared to this end, but from the first one, etiology of ESRD, so hypertension took a lead and diabetes as a major cause of ESRD, and then we had comorbidities, hypertension, and anemia actually the leading in that case. So the biological parameters, we also try to compare them, and then the types of access. So we found out that most patients use catheter access during dialysis, and very few use fistula. Now, if you check on your records, you'll actually notice that fistula has a better outcome in regards to management of end-stage renal disease, as opposed to using a catheter, which is used more often in Kenya. And also to note that catheter comes with a lot of complications that include sepsis, which we'll look into in a few. And then we had a few patients missing out. And then, so 66% of the patients we analyzed the data were alive, and then 34% were dead, which actually is a very big percentage in that regard. So this result has the unadjusted odds ratio with a confidence interval of 95%, with a p-value of less than 0.005. Much more focus on the adjusted odds ratio, which is on the right side of my presentation. So all the ones I have highlighted in red had a significance. So to mean, like the male gender, they were 2 times more at risk to die of SID as compared to the females. Then rural residents as compared to the urban residents was like 3 times higher. So if we had time, we'd have actually gone through that, but that's actually what is the interpretation of that slide. So the discussion bit of it is that KNH has a 34% mortality rate as compared to 22% in the United States, 25% study done in Peru. And then all these were associated with poor quality care prior to referral and financial constraints. Now we also have the age. So we determined that age greater than 50 was associated with a lot of inpatient mortality, and an lack of insurance also had an increase in in-hospital mortality rate for that matter. Factors that increase risk of mortality as well, we established things like hypertension as a comorbidity, catheter for hemodialysis access, which I already mentioned, a potassium of greater than 5 at admission, and as we all know that from our internal medicine knowledge, that hyperkalemia is associated with arrhythmias and increased cardiovascular related mortality in SRE patients. Now lastly, I also mentioned that catheter for access is associated with higher mortality due to an increased risk of sepsis. Now the limitations for this study was we used secondary data, and thus there were difficulty in retrieving some data. 2, we were unable to plot a survival curve analysis, which we really desired to do, and this would have helped us in doing out a regression analysis to confirm the duration of time someone takes before they pass upon admission at KNH. In conclusion, we figured out that the rate of death among SID patients is significantly high. 34% is excessively high. And 2, prevention and treatment of comorbidities and the resulting complications would significantly lower the mortality rate in our facility. Lastly, the best way to avoid and manage end-stage renal disease is to take a complete and integrated approach to manage hypertension and diabetes, mostly in our population, because these two are associated with a higher comorbidity and a higher morbidity and mortality rate among the study patients. I have 1 minute for my audiences to have any questions. These were our references. If you have any questions maybe on this study and any input that you may want us to consider in as we move into the future. Back to you, my audience. Thank you. So I will say, do you have any questions, or I save the next minute for my next presenter? Thank you. We can all enjoy our lunch.
Hey, pick him up, copy this guy.